All right, guys. So what's going on today? I heard we're going to be discussing some K-pop. Is that correct?
That is
Gangnam
correct.
Style.
Gangnam.
No, it's not K-pop.
What? No. What's
No,
going
K-pap.
on?
KPAP. We have
K-
Dr. David White with us. He's going to be talking about the Kairos PAP or Kairos PAP, maybe said a little bit better. But he's working with our good friend Dr. Bill Noah, who gave us the VCom, and they've developed an algorithm that reflects some of the actions of the VCom, and it'll be fun to get to dig into that today.
Now
I
that
can't
sounds
wait for the
cool.
industry to get one more tool to, help patients with their sleep apnea. Even some of the alternative therapies that are starting to, become more elevated in the conversation around treatment options for patients. Have a 50 percentile, improvement in the patient's overall, sleep apnea index. This might be the thing that is actually comfortable to wear during the nighttime, and is this, has the same efficacy as, what we know as traditional CPAP therapy. So I'm interested to see what he has to say.
So it's interesting you're saying that because if you think about it, 20, 30 years ago, we were talking about this thing called CPAP, and it was the increase in awareness of sleep apnea and getting patients taken care of. And now it's like a second wave. Like you said, Robert, you have these alternative therapies coming in. We've had people who were associated with dental device on the show, and we've also had somebody a while back that was talking about the Inspire, the neuromodulation. So it's interesting to see that suddenly the season of change has started taking place in terms of CPAP.
Well, I think that everyone understands that we need more options, we need better solutions, and that we can do better. And if we can do better for patients, then we should do better. Just because it there has always been a solution that is the gold standard. Maybe the gold standard could become the platinum standard
There
if
we
we do
go.
it better.
Yeah. So Emerson, what can we expect from today's call? I mean, we've all worked at some time or the other with Dr. White. So what do you think the listeners can
Well,
expect?
what I hope we hear today is really what's behind the curtain on this. It's one of those things where we all had our experience with Flex, and we went out and had people breathe on it, and breathing was believing and all those good things. But I'm hoping that we get a deep dive, we get a better understanding of what Dr. White, Dr. Noah, and the others at Harvard are working on to help us understand what this therapy is and how it can work. Because to both of your points, it's what we have right now is just not working adequately, and we need something better. So I'm excited to see what happens today.
All right, then, let's go to the show. Now, a word from our sponsor, MedBridge Healthcare. MedBridge Healthcare is a leading provider of sleep lab management services and home sleep apnea testing. MedBridge partners with hospitals, healthcare systems, and medical academic institutions to offer comprehensive, fully integrated services for sleep disorders.
Lights out.
All, all right, welcome everyone once again to another episode of Sleep Tech Talk, the sleep podcast with your hosts and friends, Emerson Kerr, Robert Miller, and me, Dr. Gerald George Mannikarote. Folks, we have a great guest once again. You guys know we're always on top of the latest technologies. Hey, sleep tech, we're always on top of that. You hear it first over here. And with that being said, we have an excellent guest, an amazing guest to talk about one of those newer technologies. But before we do that, we just want to say thank you so much for all the likes, all the subscriptions, and all the shares. We can't do this without you. So please continue to share the podcast with all your friends, those who are in the industry and those who are curious about the industry. Just send it over, share it with them. And a huge shout out to our sponsors. We can't thank them enough for what they do for us. Huge shout out to them. And with that being said, Emerson, what's going on today?
Well, Jerry, thank you so much. We have David P. White, MD, with us, Emory University Medical School graduate, trained in internal medicine and pulmonary disease, at the University of Colorado. Currently a part-time professor at Harvard Medical School. He is a past president of the American Academy of Sleep Medicine, chaired the NIH's Sleep Research Plan Task Force, and was editor-in-chief of the Journal of Sleep. He contributed to test writing for the American Board of Internal Medicine and served as chief medical officer for Respironics and Philips Respironics. With over 275 publications, his primary research focuses on sleep and breathing disorders pathophysiology. Dr. White, we are absolutely honored that you're with us today. Thank you for taking a little bit of time to visit with us. You've done some recent research and work with the Kairos CPAP, and you've got an upcoming webinar that Sleep World Magazine is sponsoring, the Kairos PAP or KPAP, Pressure at the Right Time, the Future of PAP Therapy for OSA. It's scheduled May 29th, May 30th, again, sponsored by Sleep World Magazine. How did you get involved in the KPAP? And I understand there's a bit of a backstory there that we would enjoy.
I was contacted by Bill Noah, who's really sort of the brainchild of KPAP, probably about 9 months ago. And he called me and says, you got to try this new CPAP. But I got to tell you, I was totally disinterested. I have spent the last 25, 30 years of my career trying to get past CPAP, because I've never thought that CPAP was, sort of a barbarian treatment and we needed to do better. And I thought the field would fail if we didn't get to more easily usable and more scientifically sound approaches. But he said, try it. He said, I'll send my engineer out there tomorrow and let you try it. And so he came out here and he put me on regular CPAP, which I've used plenty of times before, just in experiments. And then he switched me to this new pressure algorithm that he developed. And it was remarkably better. This was not a subtle change in the pressure. The whole breath felt infinitely more comfortable, more normal. And so I became convinced that this was, something worth developing. We, over that last 9 months, have thought about the physiology some more. We've tested its efficacy. We've seen its comfort ratings and things like that. So I'm, as with the title of the upcoming talk, I'm convinced this is going to be the way CPAP will be delivered in the future.
When you're talking about the research, that I'm sure there's quite a bit to dig into with that. Can you give us some insight into what research is currently going on and what have been some of the learnings about that? For those of us that are with you today, we certainly had our experience with the flexes and we know about EPR and things like that with pressure relief. What is it in this research that's compelling to you, that's going to really lift and give the patient a better experience?
What we've realized is that all efforts to date to make CPAP pressure more comfortable, I'm not talking about masks or humidification or any of that, we're talking about pressure. All efforts have been based on lowering EPAP. That's just been the goal. BiPAP came along, and C-Flex came along, and EPR came along, and every one of them lowers the EPAP. And logically, that makes sense, because you think, gosh, leave the IPAP where it is, because that supports inspiration, which ought to reduce the work of breathing. Let the EPAP go down, because the work against, it's against expiration and increases the work of breathing. So it all made perfect sense. But the problem is, if you looked at the data, two data sets. One, if you look at what lowering the expiratory pressure does to the airway, you'll find that the airway shrinks in size. I mean, you clearly lose pharyngeal patency as you lower EPAP, and you don't gain it back by turning it on or higher pressures and inspiration. So you're just trying to force air through a smaller tube is all you're doing when you lower EPAP. And all the studies of every one of the EPAP reduction algorithms that I just described to you show no improvement in adherence. Meta-analyses have been done, individual studies, it doesn't improve adherence, and it therefore doesn't work well. If you make the airway smaller and try to force air through it, that's not an improvement. And as I said, it doesn't improve adherence. So we recognize that is a problem. And we thought, well, what can you possibly do? And the idea of lowering inspiratory pressure came out of sort of two thoughts. One was that sleep apnea patients don't need you to breathe for them. I mean, obesity, hypoventilation, COPD, neuromuscular disease, they may need you to breathe for them, but sleep apnea doesn't. They can breathe just fine on their own, so they don't need inspiratory pressure. And number two, and this is speculative, it just seemed to us that, gosh, when we take an inspiration, you're absolutely used to the exact rate of inflation of your chest walls, the muscle shortening, the inflation reflexes in the chest and in the lungs. You're used to those and they feel perfectly normal. When you put someone on fairly high IPAP, it just blasts the air and it changes the whole dynamic of the inspiration, and it's not comfortable. And we thought, gosh, if you lower that pressure, the person can sort of dictate the pace of flow and the pace of chest expansion, and that will end up being more comfortable. And so what we originally did was we lowered, in one step, we lowered the pressure right at the beginning of inspiration. We tried a whole variety of permutations of that. And what we landed on was the idea of doing 2 drops during inspiration. And they can be whatever you want, but what we've generally found to be most comfortable is you drop it a couple of centimeters immediately on the onset of inspiration. We drop it another 3 centimeters once you reach the peak inspiratory flow. And then when you go into expiration, the pressure is already down 5 centimeters of water. Okay, down 5 centimeters. That's a lot. And all the other algorithms have to recognize expiration and then try to drop the pressure immediately because they are already at the inspiratory pressure when expiration begins. Okay, and then about roughly halfway through expiration, we gradually bring the pressure back up to the optimal or the therapeutic level, and you have it there long enough that it reestablishes the patency of the airway such that you haven't lost that airway patency that you have if you left it there throughout the entire expiratory cycle. So you bring it back up at the beginning of the towards the end of that expiration. And so when the next inspiration begins, you can start all over and drop it again. And it turns out that this is remarkably more comfortable. And we've taken hundreds of patients and tried them on various permutations of this and compared it to CPAP. And somewhere between 90 and 95% of people will tell you this is more comfortable. I like this better, much better than I like CPAP. And we've also were in the process of finishing up a sort of a head-to-head trial where we put people on 95% pressure versus we put them on KPAP and look at the apnea apnea index. We look at the APAP, what it can do to the pressure drive. We look at all this, everything, and basically there is no difference in the apnea apnea index whatsoever when you put them on this algorithm, despite the fact that during most of the respiratory cycle, your pressure is 5 centimeters lower than it is the normal holding pressure would be. So we think this is, I'm not saying it's more efficacious. It's not. I mean, you don't get a lower AHI because these people are all pretty well treated. Most of the AHIs in these studies we're dealing with are about 2 or 3 on positive airway pressure. But we think it'll lead to better adherence. I will also say we have not documented that though. We're planning a study where we're going to do a 6-week crossover study between regular APAP versus APAP with the KPAP algorithm and see if indeed this added comfort does lead to improved adherence. But that's pretty much where we stand right now.
Dr. White, the patient population that you've tested, the severity level of their OSA, do you have patients that have really severe acute OSA that are part of the patient population?
They were basically just a sequential group of patients in the laboratory that were coming in to get their CPAP. They'd been diagnosed, with all the severity. They were coming in to get it. We asked them if they'd be willing to participate in a little research study, took them aside and tried them on a variety of pressures, both with KPAP and with CPAP, and they reacted to it. Yeah, so there were very severe people and mild people, everything.
Fantastic. And I'm glad to hear that the outcomes are what you had hoped for, that the HIs would be similar between the new therapy and sort of the historic therapy. But how did the industry get this wrong? For so long, how have we sort of all worked, with this higher expiratory pressure, trying to, or I guess trying to have expiratory pressure relief, and higher expiratory pressures, just assuming that was the proper way to ventilate a patient that needed CPAP therapy.
And if I
I
could
think
just add to that, Doc, because Robert makes a really good point. How did the industry get it wrong? Because, like you said, Doc, it's like common sense. This intuitively you would be thinking expiratory pressure, lower it, and that's what everybody's thinking right now. Is that how are you turning this on the head?
I mean, I can't say much more than you have just said. I mean, I think it was what people did seemed very logical. Okay, it seemed very logical. That being said, you can go back to the 90s, okay, back to the 90s and look at papers that showed several things. One, they had imaging of the pharyngeal airway with an MRI or CAT scan, mainly MRIs, and they showed the airway size during spontaneous breathing. They showed the airway size during CPAP, and they showed the airway size during BiPAP. Plain as day that the airway size during BiPAP was substantially smaller than it was during CPAP. And so that data was there. If you looked at actually flow patterns on somebody, if you put them on, say, 11 centimeters of water, CPAP looked at the inspiratory flow patterns during sleep and gradually reduced the EPAP, okay, reduced the EPAP, flows deteriorated, flow limitation developed, all kinds of things, bad things happened to the airway. So the data was there, but it was pure physiology data, and everybody was thinking the way you're thinking, that the way pulmonary people thinking that IPAP is going to reduce the work of breathing, EPAP increases work of breathing, therefore let's go with it on that way. The other problem I had was that I think everybody thought that putting reasonably high pressures during inspiration would dilate the airway, which it doesn't do. It's a fairly complicated physics as to why that's true, but it does not dilate the airway the way you would think it do. EPAP is the main variable that does that. So I think it's just normal logic, what we thought, not paying attention to some, not obscure necessarily, but some papers that were out there that if we'd have listened to them or thought about it, we might have come to this conclusion a long time ago. But I think that's the only explanation I can offer for why we sort of got it slightly backwards.
Are you a sleep tech looking for new opportunities? Well, MedBridge Healthcare is one of the largest employers of sleep technologists, and they are growing. If you are a sleep technologist interested in a new position, potential paid relocation, or looking for a career advancement, consider a career with MedBridge Healthcare. Now back to the show.
Do you have any theories, Dr. White, on complex sleep apnea? Will this have an effect on those patients that maybe were over titrated, had that sensitivity to pressure, maybe had the Herring-Bauer reflex, something of that nature? Have you thought about that any, and how this may play a part in that?
We thought about it a lot. I mean, if you look at complex apnea, or particularly, let's talk about treatment emergent central sleep apnea, okay? If you think about that, what everybody's been saying, or everybody's been thinking primarily, is that these people, the thing that causes sleep apnea, there are a variety of endotypic traits that I've developed over the years to define what causes sleep apnea. And one of these is a tendency towards unstable ventilatory control, meaning the mechanisms that control ventilation can be unstable. And if you've got absolutely overt unstable ventilatory control, you have central sleep apnea, okay? You cycle. Airway obstruction is not the issue. However, some people that have that have propensity for airway collapse, but also have high, close to unstable ventilatory control, and we call that high loop gain. Loop gain is just an engineering term for the gain of a physiological feedback loop, which respiration and carbon dioxide in the blood are, where they feed off each other. Anyway, with that being said, if you're going to tip somebody over from being roughly stable to unstable, all you got to do is give them a little bit of extra pressure support. If you give them a little bit of extra pressure support, it makes them breathe a little bit more on these when they're during their inspiration, and you can make them cycle. And you can take anybody and give them enough pressure support and make them cycle. But if people that are naturally close to cycling on their own, if you just tip them over with a little extra pressure support, they're going to cycle. And that's what and every time you lower EPAP relative to IPAP, you're giving people a little bit of pressure support. I mean, BiPAP's overt pressure support. C-flex and expiratory pressure relief are subtler, but they're still 2 or 3 centimeters of water of pressure support. And I believe that tips these people over into developing central sleep apnea. And we looked at some of Bill Noah's data, and they went back and looked at thousands of sleep studies, and they found that the number of people developing TECS, or treatment emergent central sleep apnea, if you titrated the CPAP on a device with expiratory pressure relief, either CPAPs or expiratory pressure relief, was 8 times higher than if you just titrated them on straight up CPAP. Okay, 8 times higher. And so it suggests that these maneuvers that we were doing were generating, CPAP, central sleep apnea. They were producing it. And then he stuck this VCom device in, which is just a little resistor you can stick in the inspiratory line that lowers inspiratory pressure. It's not the whole algorithm we have with KPAP, but it will lower inspiratory pressure. If they did that, all of the TEXA went away. It just disappeared because you reduce that pressure support. So, our recommendation to people is going to be, if you see TEXA, first thing you ought to do is get rid of expiratory pressure relief or BiPAP if you've got that going, and see what you've got. And if it's still there, you could try a VCom. And once this algorithm, the KPAP algorithm, comes out, I mean, it's going down considerably lower on inspiratory pressure than even the VCom, unless you put 2 or 3 VComs in series. And so my guess is you'll see almost no CPAP, central sleep apnea emergent from titrations, or even with the APAP and stuff. So we think this will reduce that a lot because there is no pressure support.
Dr. White, one thing that I'm hoping with the more widespread use of KPAP in the future is the death of the full face mask. I'm not a fan of the full face mask, and I do know in some of my conversations with Dr. Noah that there seems to be less oral venting by patients. I.e. the lack, or you don't necessarily need to use full face masks to prevent oral venting for patients. Is that still a continued benefit of the KPAP?
We think so. I mean, that has not been tested. The problem with the good news about full face masks was that they have no airflow resistance. So if you set the algorithm basically to full face mask, you don't get the extra. And I didn't talk about that. When they did these algorithms to deal with the high resistance of the nasal pillow masks, the small nasal pillow masks, they turned up the IPAP. Okay, that's how they dealt with it. And so you're not setting that all. You just say patients on nasal pillows and they get a higher IPAP than EPAP, and that can cause problems. And so what we think you ought to do is probably just put everybody on full face mask settings, but not use a full face mask, put them on nasal, because you don't need that extra IPAP. It doesn't help them. They don't need you to help them breathe. And it's just another inching towards more inspiratory pressure and less expiratory pressure, which produces the problem. We think pressure is part of the problem in terms of mouth breathing. The higher the pressure, the more likely you're going to mouth breathe. And therefore, if we reduce it on inspiration, it ought to reduce that. And Bill says in their lab, they have basically had people that are struggling with nasal masks that they would have normally gone to a full face mask, that are basically becoming intolerant of the titration. And they've stuck these VCom devices. And again, recognize VCom doesn't have all the advantages of KPAP, but it lowers IPAP. And in the majority of the cases, the patients finish the study out nicely still with a nasal interface. So I think there's a reason to believe it's possible. But I mean, again, that's sort of soft data, but we'll have to see what happens over time.
Doc, we are getting close to time, but I do have a question for you, which is, where do you see the future? You said at the beginning you didn't want to be involved with CPAPs because you felt it was old technology and there's got to be something better. So where do you see the future?
I mean, I think it's actually a pretty exciting future in sleep apnea. I'll make this sort of. I think we're going to make CPAP better. As I said, I can't imagine in 2 or 3 years that people are going to be on CPAP delivered the way it currently is, just for the comfort issue. There are a lot of other new things coming down. There's a drug combination. Drug's called AD109 right now, coming from a company called Apnea that is well into phase 3 studies. And if those things come out as predicted, which all evidence suggests they will, we'll probably have this drug combination available probably in early 27 for treating sleep apnea. There are several other companies that have very novel approaches. One uses a nasal spray, not to open up your nose, but to activate the upper airway muscles through a very important physiological mechanism that may treat sleep apnea as well. So that's interesting. There's a company called Cryosa that is applying cold therapy to your tongue, uvula, and soft palate, just like people are doing to their stomach to get rid of fat. It removes fat from the airway. So increase airway size is another way to treat sleep apnea. There are two new companies coming out with stimulation devices that are quite different than Inspire. They're trying to do roughly the same thing, but very different ways. So there's a lot of activity in terms of the CPAP. I'm not CPAP, the sleep apnea therapy world. So I think it's an exciting time. In the next 5 years, I think we're going to have a lot of options for people.
That is exciting, Dr. White. I think that, I would love to have you back to really drill down into the future of therapy, because it sounds like we have a lot of topics to talk about. Just to
Happy to
wrap
do
up
it.
on KPAP, when do you feel like it's going to be commercially available to the public? Is there a sense of a timeline with that? And as you look into the future, how do you think KPAP could affect other things like what we do with ventilation and more complex technologies?
To answer your first question, best guess, it'll be Q1 2025. Okay. 9 or 10 or 11 months from now is our best bet right now. It's a lot of complicated things happen to that. We have to get FDA approval and whatnot, but that is sort of our best guess. We've got some other ideas that may be useful in invasive or non-invasive ventilation. It's not KPAP though. KPAP's focused on trying to reduce inspiratory pressures and keep it off as long as you can during expiration. And that's not what you need during ventilation. However, during ventilation, we are developing methodologies that will look at your lung compliance and deliver set the EPAP and set the IPAP at your optimal lung compliance, things like that, to sort of optimize the minimum pressure you'll actually need to ventilate you and probably do it the most comfortably, things like that. But that's not what KPAP is. It's a totally different technology.
Well, Doc, it's been really exciting hearing all of this and the developments, but we are out of time. Where could people get more information about you and about KPAP?
Well, we're going to start publishing some papers. One of them is right now we've submitted some papers with the VCom. We haven't submitted anything with KPAP because we're just getting that going right now. If you want to learn more and have more detail with a lot of drawings and figures and stuff, you can come to the webinar that I'm going to do on the 29th and 30th of May through Dream World magazine. And I'll explain in detail exactly how the whole thing works, show you the actual data and all of that. So I think that's coming. We'll be publishing everything we do will get published in peer-reviewed journals, but they're not out there yet. We just got some stuff with VCom, but that's coming.
Awesome. Thank you so much, Doc. We sincerely appreciate you joining the show.
My pleasure.
And folks, thank you all so much for joining us as well. Another fantastic episode, as always, with an amazing guest. We thank you so much for all your likes, your subscriptions, and especially the shares. Keep sharing the podcast with all of your friends and all the professionals in the sleep world. And a huge shout out once again to our sponsor. With that being said, thank you all once again, and lights on. Before we go, we would like to thank our sponsor, MedBridge Healthcare. MedBridge Healthcare is developing innovative inpatient, post-discharge, and population health programs to screen comorbid conditions, diagnose, and treat sleep disorders. Learn more about their innovative solutions and career opportunities at medbridgehealthcare.com. Once again, you can learn more about their innovative solutions and career opportunities at medbridgehealthcare.com. All right, guys, post-cals. Another show, another post-cal segment. So what did you guys think?
Well, Dr. White definitely delivered on what he always does. He's such a wealth of information. We could have talked to him for hours about all that he's doing in sleep, knows about in sleep. We definitely have to have him back, but I really appreciate the deep dive he took into the KPAP. I think what it begins to do is really bring up other questions, things that the three of us have done for years, from BiPAP rescue to auto servo ventilation. I mean, everything comes into question. If this proves out to be as effective as they hope it is, it could certainly change how we treat patients with sleep disordered breathing in a comprehensive way.
The interesting thing, Emerson, is that their greatest struggle in trying to bring this to the market may not necessarily be the results of the therapy as much as the tradition of what we've always known as CPAP therapy. So, it's sort of climbing the mountain of tradition, if you would, or against the mountain of tradition, if you would.
Well, I think
And
you're absolutely correct, where it flips everything on its head.
it
Right.
does.
Everything that we've been talking about for the last, gosh, all the way back to Dr. Sanders, and maybe even further back when you get all the way back to the original CPAP in the early 80s, it flips all of it's on its head of how we think about breathing, how we think about the airway, that linear process that we all were married to. It flips it in a completely different direction and challenges us to think different about how somebody breathes and how we should support them.
And for us three, we've had the opportunity to actually breathe on the algorithm, so we have a unique perspective in that we sort of know what's coming, at least from a personal standpoint, and how we were able to tolerate, this new KPAP therapy more so than what we would traditionally know as CPAP therapy, and at much higher pressures. By the way, it was unique. I remember being able to, talk normally even though I was on, KPAP of like 15, I think. So
Wow.
it's a completely different experience than what you would expect CPAP to be.
Well, I think that it raises even a bigger question now is, okay, what does this do to adherence? What does this do to all these efforts that we put into coaching? Because so if really what we're battling is just an extraordinary discomfort that the patient has, and we can change that, it changes all of our processes. It changes how we think about post-therapy management and what we're going to do with the patient, and what does that care plan look like. So there's a lot that could happen with this. I hope that it delivers on, the clinical research gives us something to look forward to.
I completely agree. I was waiting for Jerry to jump in.
He looked like
No,
he
but
had
I'm.
lots to
He
say.
did. He did. But I think Emerson. The only thing that is unfortunate is that we still are 9 to 11 months away from
Yeah.
seeing this therapy come to market. And we there's so many things, and even with the other therapies that are out there and the other, even some of these pharmaceutical things, it feels like that there still is a co-therapy opportunity for a lot of patients with a much lower pressure, maybe even a different type of pressure with this KPAP, along with a pharmaceutical solution, or even an oral appliance solution along with the PAP. Whatever the case may be, whatever the perfect combination is for a patient, because the most important therapy for a patient is the therapy that the patient can tolerate and use and that is effective.
Well, and I think that last statement, is it effective? It leads you to, why, we have the issues with AHRQ and others saying that CPAP isn't effective. If they can actually wear it for 6 to 7 hours, and now they can tolerate it all night, and then ultimately it be effective, then we could probably look at new research on, what is the impact of CPAP on hypertension and diabetes and chronic diseases. I think that, that's what we're facing right now, is that the current model is proving to be ineffective in patients with chronic disease. And that's unfortunate, because it's exactly what we don't need to have happen. And if we can make it easier for the patient to breathe on therapy, my gosh, it changes everything.
But I would love for us to have Dr. White back when they have sort of perfected their ventilator technology, because that's a much more acute, vulnerable respiratory patient that, certainly anything that they can do if it's, changing the algorithm or thinking a little differently than how we've done it in the past, you know, it, the adherence is always higher in that patient population, but it's because of necessity more than it is, anything else. But if you could, even prolong and improve the outcomes of those patients while they're on a ventilator device, that I think that could be an incredible, you know, achievement as well.
Agreed. Well, that's why I asked that question at the end, because I wanted our listeners to understand that what we're talking about is something completely different than what we would see in ventilation, because what we've seen in ventilation is the inclusion of the flex technology in some cases. And in this, we're looking at it completely different. And I felt like it was important there at the end to contrast those two so that we could look forward to that. And now we've set ourselves up for something in the future to hear about, which will be really exciting.
So for me, what you had said, Emerson, earlier about where is this going to take us in terms of long-term use, long-term results, or long-term outcomes. And that was actually what was going on in my mind is where is this going to be 3 years, 5 years, 10 years from now? How is this going to affect us? Is it, from when you're looking at patient outcomes, and then you're looking at the socioeconomic side of it, of healthcare, how is this going to change things? We all know very well, to your point about diabetes and hypertension and all those sort of things, and how effective usage of CPAP is towards this. Yet we have this issue of compliance or adherence to therapy. Now, if Robert, you were talking about this just now about how with the use of this, there's a possibility of better adherence to therapy. So if that's the case, how much effect is this going to change or have on the healthcare system in general for patients across the country, across the world? It may be a true cultural shift, or not a cultural shift, a socioeconomic shift in the right direction if all this goes really well. And again, to your point, unfortunately, we're going to have to wait several months before we could get to find out how much difference this is going to make.
You know what the best part is, Jerry? The
What's that?
entire audience got to hear it first here on Sleep Tech Talk, because we
right.
are the launch pad of the sleep startup.
That's right, folks. You heard it here first.
No, it's good stuff, and everybody should tune in to the webinar that Dr. White
Yep.
Is putting on. If you haven't registered for that, maybe we could put a link in the commentary for the podcast so that everyone can get signed up for it. We absolutely feel like everyone should be listening in and participating in that conversation because it could be a game changer for sleep medicine.
Yeah, Sleep World Magazine, May 29th and 30th.
All right, guys. Thank you very much. And folks out there, thank you all. And we're going to try to get as much of the information in the show notes for you. Be sure to check it all out. And everybody that stayed on till the end, thank you so much. With that being said, until next time, thank you so much. Cheers.